So I'm
Okay.
Anup Pandey, Medical Officer at Poison Information Center, TU Teaching Hospital, and I'm presenting a case of plant fertilizer poisoning, NPK, that stands for nitrogen, phosphorus, and potassium. This is a case of mixed poisoning consisting of NPK and phenol. So I'll be basically focusing on NPK rather than phenol because this is one of the cases we'll see less frequently in our setting. So we'll be discussing on these four agendas basically. So on August 13, we received a case of 24-year non-pregnant female who ingested NPK fertilizer followed by phenol approximately 100 milliliters and was brought to Pokhara Hospital and Research Center, and we received call at 20:30 from the hospital about if there is any antidote regarding NPK poisoning. At the time of presentation, the patient's vital was stable. The patient was conscious, alert, well-oriented to time, place, and person with GCS of 15. This is a representative image of NPK poisoning fertilizer commonly used in our part of the world. And the brand was not could not be identified. We could not identify the brand name. The compound was NPK fertilizer consisting of nitrogen, phosphorus, potassium, followed by phenol. The amount of NPK that was ingested could not be calculated. However, 100 milliliter of phenol was ingested approximately, and she ingested the poison at around 18:30 evening time with suicidal intention. So at the first phone call, we advised contraindications of gastric lavage consisting of since there is no proven benefit of gastric lavage in NPK and phenol is a corrosive poison. So for both of the poisons, the gastric lavage is contraindicated. For one, it is there is no proven benefit, and for another, gastric lavage is contraindicated. And within 15 minutes, we consulted with the international experts and advised to send for basic labs and plan for endoscopy 24 hours later while monitoring for methemoglobinemia. The ECG was normal, basic labs were normal, and the patient was planned for referral to center with endoscopic facility. So on the same day, the patient refused further investigations in the center with a plan to visit the higher center, and the patient was referred to Gondagi Medical College. So after 45 minutes, we contacted Gondagi Medical College for follow-up. However, they did not give us the information that the patient was there, and we recontacted Gondagi Medical College the following day. In the morning, the patient did not arrive there, and we declared the patient lost to follow-up. Hopefully, the patient was well, then the patient recovered. However, there are things that could have gone worse, and we shall discuss about the toxicity, discussing what could have gone wrong. So, on considering the toxicity of NPK, it contains nitrogen, phosphorus, and potassium. So, if ingested in large amount, it could result in hyperkalemia. The risk of hyperkalemia further increases in those with renal impairment, and the patient could manifest with diarrhea or metabolic acidosis, renal failure, or nitrates are expected to cause methemoglobinemia only when they are ingested in large amount. So, considering the toxicity of phenol, phenol is an irritant at low concentration, and it is a corrosive at high concentration. It is rapidly and well absorbed by all routes of administration, and it has varying presentation ranging from simple GI upset to shock. The patient can present with laryngeal edema from the corrosive effect, and there may be metabolic acidosis, high anion gap metabolic acidosis, and the CNS toxicity may manifest as respiratory depression, bronchospasm, to acute onset, even pulmonary edema may be present, and methemoglobinemia may be present here as well, and acute intravascular hemolysis has also been reported in one case. So skin and eye irritation can occur in low concentrations of phenol. However, even blindness may occur when the concentration is high or when the exposed amount is high. So considering about the management, we have to always follow the ABCD approach, maintaining a clear airway, ensuring adequate ventilation, administering oxygen, and establishing IV line, monitoring vitals, cardiac rhythm, and checking capillary blood glucose level. These are the basics we do in all cases of poisoning, basically in all cases of that arrive to the emergency setting. So diagnostic clues regarding NPK poisoning. We should always look for patient's history, and if the patient party brings any packets or bottles around the site of incident, even if they don't bring it to the ED, but they may report finding of any packets or bottles or any chemicals they may recognize, so they may present with such features, and we should consider methemoglobinemia if unexplained sinuses persist despite adequate oxygenation. So, considering management and decontamination, gastric lavage and activated charcoal is not recommended, and gastric lavage is contraindicated in phenol poisoning, and there is no proven benefit in cases of NPK poisoning. So, skin decontamination may be required in cases of local exposure because phenol is absorbed through the skin as well. So, if there is a local exposure to the skin alone or along with skin, there may be ingestion, skin decontamination may be required. And investigations and monitoring, we should always obtain baseline investigations like complete blood count, renal function test, including electrolytes. I'm focusing on electrolytes because we've already discussed hyperkalemia as a potent side effect or a potent toxicity, and LFTs and methemoglobin level if available and in suspected cases. So we should monitor them regularly in all symptomatic patients or if patients present with any abnormal finding or if their conditions worsens. We should perform chest X-ray and we should consider chest X-ray for signs of acute pulmonary edema, and urgent imaging or endoscopy should be considered in cases that present with drooling, dysphagia, vomiting, or severe pain, hematemesis, stridor, because they may be associated with more severe injuries than we can appreciate from the outside. So considering management in critically ill patients, those who present with tachypnea, stridor, or signs of upper airway damage may require critical care support, and we should always consider for endotracheal intubation or emergency tracheostomy if we cannot establish a secure airway. So supportive therapy is the mainstay of treatment as we don't have particular antidote, and we should consider the use of water or milk. The maximum initial volume should not exceed 100 to 200 milliliter in an adult or 2 ml per kg in a child. As diluents for symptomatic benefit early after the corrosive ingestion, provided that the patient does not have swallowing or breathing problems. We should always remember the patient should not have swallowing or breathing problems. However, administration of large volume of fluids should be avoided as they may induce vomiting and further increase the risk of edema. And considering the use of antacids, it has not been studied in detail, but they may be helpful to reduce the extent of corrosive injury if we give them early in the case. So considering the management for hyperkalemia, we can follow the conventional management using calcium gluconate, nebulized salbutamol, insulin, and dextrose. And for methemoglobinemia, which is a rare complication, it will be warranted in patients who develop sinuses despite giving adequate oxygen therapy and those who do not respond to oxygen therapy. However, this will be treated with high flow oxygen even if they don't respond, and antidotes will be considered with IV methylene blue. However, vitamin C can also be considered for cases of methemoglobinemia because it helps to change the iron from ferric form to ferrous form, which has better oxygen affinity. So hypertension, if present, will be treated with aggressive fluid resuscitation or blood transfusion if necessary. So considering metabolic acidosis, we should start sodium bicarbonate if acidosis is present despite the fluid resuscitation. And considering dialysis, there is no indication that phenols are removed by hemodialysis. Charcoal hemoperfusion has been shown to reduce concentration of phenol in one case. Still, hemodialysis may be useful when there is cases of renal failure to support the renal function, not to actually remove the phenol, but to support the renal function. Hemodialysis may be helpful. So finally, before discharging from the hospital, all the survivors with swallowing difficulty should undergo upper GI endoscopy for detection of any esophageal complications that may be stricture, any edemas, or we should look for GI endoscopy so we can predict the complication in the future and if there is any preventable approaches, then we may apply it. So we can consider discharging the patient at least after 6 hours of observation. If the patient is asymptomatic, if the patient has resolved drooling, pain, or stridor, if anything was present, if the patient is able to eat and drink easily and safely, and there are no signs of systemic toxicity, and the patient should be advised to return if symptoms develop or worsen. And last but not the least, psychiatric counseling is must, and we should ensure psychiatric counseling in all cases of suicidal ingestion. So we have received, the Poison Information Center has received a total of 3 fertilizer cases of poisoning, and previous ones were biofertilizers, including bone dust. But this is the first case of NPK fertilizer poisoning, and that's all on my side. These are my references. Thank you.
Thank you, Anup. That was really good. Does anyone have any comments, questions?
Yes. Anup, this very good presentation. You have elaborated the complete management, and you have nicely put the clinical scenario of NPK poisoning. So I would like to ask you, can you please go back to your slide and show me what were the symptoms that the patient presented when he was in the ER? So what was his complaints?
So there were actually, the patient was not asymptomatic. The patient was brought by the family members, considering if there could be any possible effects that may be present later on, considering a suicidal ingestion. The patient had no symptoms at the moment, but she was brought to the attention of emergency department by her family members.
So after she landed in the emergency, were there any symptoms developed later on, or she didn't have any symptoms?
No, she did not develop any symptoms in this case. Probably that's why they were lost to follow-up. They did not visit the higher center that they were referred to.
Okay. So did you get chance to have a look at the literature, and did you mention atropine, by the way, during your presentation? If I have missed that one, atropine.
No, sir. I saw.
So is there any? Yeah.
Yes, I saw few cases. अलिअलि केस रिपोर्ट चाहिँ थियो सर, 2टा जस्तो केस रिपोर्ट चाहिँ थियो। त्यसमा चाहिँ उहाँहरू चाहिँ त्यसमा चाहिँ हाइपर क्यालेमियाले चाहिँ अलि वर्ड्स भएर हाइपर क्यालेमियाको लागि चाहिँ ट्रिट गरेको भनेर चाहिँ केस रिपोर्ट थियो। अरू चाहिँ एनपीके को त्यति खासै केस भेटिएन सर।
So as you have mentioned that the drooling stridor was resolved, त्यो कसको हो त्यो? त्यो पेशेन्टको के कसको हो त्यो? Resolved in the, was it the part of management of overall poisoning or the?
डिस्चार्जको लागि चाहिँ हाम्रो फिनोलको पनि भएर चाहिँ त्यस फिनोलको कोरेस्पोन्डिङ इफेक्टको लागि चाहिँ त्यसको लागि चाहिँ त्यो ड्रुलिङहरु त्यो चाहिँ रिजल्भ हुनुपर्छ भनेर त्यसरी चाहिँ प्रेजेन्ट गर्न खोजेको।
Okay. Literature, I have gone through the literature, and they have mentioned that if there is any kind of cholinergic symptoms, that if the patient developed the cholinergic symptoms following the ingestion of these nitrogen, phosphorus, and potassium poisoning, you may have to use the atropine. So atropine is regarded as an antidote, even though there is no specific antidote. Based on the symptom of the patient could be an eligible candidate for the atropine. Please go through it. Basically, symptomatic treatment नै भइ नै हाल्यो, तर atropine is widely available. It's in the National Essential Drug List. It is available in every PSC. सबैतिर हुन्छ। यदि पेशेन्टको चाहिँ यदि कोरोनरी सिम्पटम्सहरु छ भनेदेखि चाहिँ atropine पनि युज गर्न सकिन्छ भन्ने कुराहरु चाहिँ मैले चाहिँ I have gone through literature. मैले NPK bar fertilizer poisoning भनेर एउटा आर्टिकल रहेछ, Indian article. I'll send you this one. So they have mentioned the use of atropine, right?
So if they show muscarinic symptoms, right, drooling, things like that you mentioned, it might be a good, because fertilizer, we knew that this was NPK that we presented, but many times there could be other pesticides that we might not know that involved. So if you have a symptomology that is, cholinergic, it might be a consideration. That's a good point, Dr. Rakesh. Any other comments? Rajesh, you had a comment?
I'll come over this side. So एउटा भनेको चाहिँ one of the thing that I'm curious is about patient being lost to follow up. So we ask the primary doctors where the patient will be referred, and then we call the hospital. But what we need to do is that we need to get the phone number of the patient, and we need to call them where they went. So normally they say we'll go to GMC, but like in reality they might be going to Kathmandu or like Manipal Hospital. So what we need to do is we need to get the patient phone number so that we don't miss them during the follow-up. So make sure we have patient phone number during these times. एउटा त्यो पोइन्ट भयो. नेक्स्ट इज अबाउट मिथाइलिन ब्लू. एज यु सेट, अब यो मेथ हेमोग्लोबिनेमिया हुनसक्छ बिकज अफ एनपिके फर्टिलाइजर्स, बट देयर आर अदर अप्सन्स एज वेल, नट ओन्ली मिथाइलिन ब्लू. किन मेनली वी आर भेरी क्युरियस for the use of methylene blue because methylene blue is contraindicated in G6PD deficiency. So I mean our population it's vulnerable and we don't do regular enzyme testing भइरहेको हुँदैन. So they might have those G6PD deficiency भइरहेको हुनसक्छ, स्पेसली फ्रम तराई रिजन होइन. सो मिथाइलिन यदि मेथहेमोग्लोबिनेमिया भयो भने चाहिँ बिकज पहिला हाम्रो त्यो इन्सिडेन्ट पनि भएको छ क्या, त्यो भयो भने चाहिँ हाम्रो सुरुमा G6PD रुल आउट गरेर अनि बेला मिथाइलिन ब्लू चलाउनुपर्छ. यस्तो बेलामा चाहिँ सेफ ड्रग टु युज इज भिटामिन सी. सो मेथहेमोग्लोबिनेमिया भयो, इफ वी सस्पेक्ट द्याट देन वी क्यान युज भिटामिन सी. किन यसको टक्सिटी पनि हुँदैन, इट्स भेरी वाटर सोलुबल भिटामिन भयो, इट्स इजिली एभाइलेबल, इजी टु युज, नो एनी कन्ट्राइन्डिकेसन्स होइन. अनि इभन लाइक अब हामीसँग मेजर्स भएन, सस्पिसियन केसमा पनि सस्पिसियस मात्रै भयो जस्तो मेथहेमोग्लोबिनेमिया जस्तो लाग्यो, तर हामीसँग ल्याब प्रुभन कुनै डेटा नहुँदा पनि वी क्यान युज इट विथआउट एनी टक्सिसिटी. So I would prefer vitamin C over methylene blue if we don't know the status of G6PD. Then
Good, thank you, Raj. No, thank you. That was really good. Anyone else that has any comments? Okay.
Last order. I'll go say like we usually
said in English.
Okay.
It's recorded.
Okay.
Yeah.
So next thing is that usually the patient goes to the hospital and they don't have endoscopy facility होइन. अनि त्यो गरिरहेको पनि हुँदैन, कहिले कहिले गरिरहेको पनि हुन्छ होला. सो मेक स्योर कि हामीले जुन डिस्चार्ज डिस्पोजिसनमा चाहिँ अब हस्पिटलबाट गयो घर गयो भने पनि लाइक वी निड टु से दम टु फलो अप विथ साइकेट्री एउटा कुरा. लाइक अनि अर्को भनेको इन कोरोसिभ इन्जेक्सन, मेक स्योर द्याट दे फलो अप विथ ग्यास्ट्रोइन्टेरोलोजिस्ट for endoscopy after discharge from hospital, because sometimes there are incidents that they come to the hospital and they don't have endoscopy facility and they go होइन, त्यसपछि त्यो पोइजनिङ पनि ठिक हुन्छ, they will go home, but they like lost to follow up at the gastroenterology, they forget to do the endoscopy and later it's a long term complication हो नि त, like esophageal strictureहरू हुन सक्ने chances, it's a long term complication of corrosive injury. So त्यो भएको within 24 hours गर्न अथवा like just after 24 hours गर्न पायो भने त बेस्ट भयो. बट इभन इफ वी कुडन्ट डु द्याट, मेक स्योर कि दे डु इट लेटर 1 month आफ्टर अथवा जे होस्. सो मेक स्योर दे फलो अप एट साइकेट्री. अनि अर्को भनेको कोरोसिभ इन्जुरीमा मेक स्योर दे फलो अप एट ग्यास्ट्रोइन्टेरोलोजी फर इन्डोस्कोपी. अनि तिनीहरूलाई भन्नुपर्छ क्लियरली कि इट्स अ लङ टर्म कम्प्लिकेसन, सो इट्स बेटर टु डु इट. अहिले केही भएन भनेर नगर्नु चाहिँ हुँदैन भन्ने कुराहरू.
Yeah, that's a very good point. I think because we don't have that many cases, we need to go above and beyond for some of these patients. Like, for example, if you get a call from a patient and they said, oh, we're going to this hospital, it's our job to make sure we call that hospital to make sure they have that capacity to take care of this patient, right? That they have atropine, that they have they have endoscopy facility if they're going somewhere, right? So if that's not happening, then you have to recommend somewhere else. So that's a big part of why we exist, and that's how we can really help these people. You did a really good job on this presentation. I really liked that you begin with a case scenario to talk about this, talk about this poisoning, which is quite important and quite common, it seems like, from our cases too. I'll say this on your presentation, everything was good content-wise. I always make sure you talk about EKG when you think about poisoning. On anything, honestly, this one particularly important because we talked about hyperkalemia, right? You talked about treatment with calcium gluconate or calcium chloride. That's determined by how your EKG looks. So not all patients with hyperkalemia require the calcium chloride or gluconate treatment, right? Unless they don't have EKG changes, you actually don't even need that. So that might be a big change for patient to, there are hospitals that probably don't have calcium chloride or calcium gluconate. So that will matter a lot in this case. And you talk about treating with sodium bicarbonate for acidosis, right? So EKG is a major part that was missing, I thought, in your initial, but I think otherwise you covered kind of a overall aspect. And clinically also, I really, on your documentation, please make sure in poisoning, EKG findings are one of the most important. So when you call the people to ask, for materials, make sure you get the EKG information. But overall, great job. We'll look forward to continued presentation from you in the future as well.
EKG को लागि
I'll
normal
consider
भनिरा हुन्छ क्या EKG मा चाहिँ they will say the EKG is normal, but make sure कि QRS prolongation छ अथवा like QT prolongation छ. You ask questions about individual, त्यो हाम्रो जुन फर्ममा छ नि, so that we get exact answers क्या. अब छैन भने त छैन हैन, तर छ भने because normally हेर्दाखेरि हैन देखिरा हुन्छ तर त्यो मिस भइरा हुन्छ कि त्यही लेखिरा पनि हुन्छ स्ट्रिपमै, त्यो एकदम इजी छ. अनि मिल्यो भने त अझ फोटो नै पठाउन भन्नुपर्छ. इजी नै छ EKG को फोटो पठाउनलाई, इन्डिभिजुअली जानु पनि परेन. तर अब ECG नर्मल छ भन्दा पनि QRS नर्मल छ, PR प्रोलोङ्गेसन छ कि छैन, QT प्रोलोङ्गेसन छ कि छैन, त्यो चाहिँ सोध्नु बानी चाहिँ गर्नुपर्छ एटलिस्ट.
Okay, great, fantastic.